I know most of you guys. I'm Weston Fisher. I'm on faculty here, and it's my pleasure to introduce our speaker today, Dr. Niraj Sehgal. He's a hospitalist here at UCSF, professor of medicine, and vice president and chief quality officer for UCSF Health. A big mentor of mine and someone who I think is doing great things for our department. Has had lots of experience both in leadership and quality initiatives over the years, with a focus on teamwork, communication, promoting a culture of learning and improvement, and a lot of emphasis on moving towards patient outcomes. He has had many different positions throughout his time here, including director of hospital medicine service, and being the director of the quality and safety efforts for the Department of Medicine. And in terms of his, pretty impressive pedigree, it's also worth noting that he was a fellow of the California Healthcare Foundation Leadership Program, and has been inducted to UCSF's Academy of Medical Educators. So Niraj is going to be talking to us today about becoming better versions of ourselves, defining, measuring, and improving quality. It's my privilege to introduce Niraj.
Nice to get a round of applause before you say anything, because they can only go down from that point forward. So thank you guys for inviting me. I'm excited to be here. We actually tend to do a lot of sessions in this space, so it's one that's known to me, which is why the mic often is not a primary source of communication. So Weston and Dominic invited me in some ways to talk broadly about quality, which can mean lots of different things for different folks. So let me start by first putting a little bit of explanation behind the title, so the notion of becoming better versions of yourself. So for those of you less familiar with medical school training, when I was a medical school first-year student back in about almost 23 years ago, the way medical school typically worked is as a first year, you would spend half a day a week essentially assigned to a precepting physician, and that was a little bit of like how you learn to be a doctor. I was incredibly fortunate. I was born and raised in Chicago, worked in that precepting mode every Thursday afternoon with this amazing family medicine physician who worked in an underserved community clinic. And he was inspirational in so many ways, and in some ways set a bar so high as my first exposure to a physician and faculty member. But one of the things that he instilled was every Thursday when I would see him, he would start our session together the same way every Thursday for an 18-month period. And the way he would start it, he would say, Niraj, how are you a better version of yourself today than when I saw you a week ago? Now, as a medical student, I hated the question because, of course, you assumed there was some answer and it was a test-taking piece. And part of what I began to appreciate over time with him, and honestly probably didn't really even appreciate as a student and only began to appreciate much later in time, was what he was really trying to instill in me was less about what I was learning, but about how I was learning and how I was improving. And so part of why, yes, today we're talking about quality, I think for those of you that either spend time involved in quality or the victim of someone else's quality effort, the principles I'm going to be talking about are not actually unique to quality. A lot of the principles of how we improve, how we become better versions of ourselves are really not unique to clinical medicine or to doing quality, whether you're a researcher, an investigator, an educator, a teacher, a clinician, a social worker. I think all of us at some level have some belief that we want to be better than we were yesterday. I think that's the frame I want you to be thinking about what you're in here today. A lot of the frameworks and principles will have some uniqueness to quality, but the principles are really, really ubiquitous in that way. So that's the setup. As Weston said, I've been at UCSF on faculty since 2003, and most of my work, honestly, has been this blend of how do I make the delivery system work better, or how do I train and develop other people to do that in their settings. And that's the latter, honestly, is some of the most fun because you get to work with amazing people across the institution and get to hear about their approach to the problems that, frankly, we all have are far more similar than different, but a lot around the approach because of it. So I think the specific goals for the sessions, my hope by the end of the session is collectively you're better able to answer the following 3 questions with a little more depth and nuance, which is what does high quality care mean? How do we approach measuring quality? And I'll give you one example of a framework that I have found very helpful over the years in this notion of what are the 4 pillars of improvement work. So that's where we're going to start. To begin with, what I'm going to ask you to do is a quick 30 to 45 second activity, which is what I want you to do is I want you to turn to your neighbor. And what I want you to do is just to have a quick conversation with your neighbor on the answer to this question. So what does high quality care mean to you? And don't overthink this. This could be a word, this could be a set of words, this could be a phrase, this could be a language. It could be a scripted definition that you've memorized for some reason. But just 30 or 45 seconds, just turn to your neighbor and say, what does high quality care mean to you when you were expressing that? Go. You can do this in 2s or 3s depending on your sitting.
I'm going to make you guys go first. I do probably body work. I have a better definition, but I don't want to.
Like a blend of obviously like
I think it has to start with
cost efficient, which both for the patient side and like the provider side.
And then section 20 care that takes care of it.
And I'm adding this to how I started thinking of it as like maximizing the time that we have. And that includes all time efficiencies, but also things like measuring outcomes.
Maybe as
That's great.
Right? And we're going to maximize for me, especially whatever it is that gets as quickly and effectively to an agreed upon that outcome could be where people are living. The measurement, I have something to put on whatever it is that's mostly your measurement agreed upon.
All right, terrific. So let me bring you back to the large group. And what I'd love to do is maybe just hear a few examples of the themes, common language definitions you were using as part of your discussions. So maybe I'll go from left to right. So if I can start with the four of you back. Maybe just an example of either, again, a word, a phrase, conversations you were having that helped define what is high quality care.
We talked about safety and evolving processes.
So safety and evolving or improving processes. Terrific.
Communication,
Communication.
and so increasing efficiencies, decreasing redundancies,
Great. So efficiency.
evidence-based.
How about the middle section of the conversations that all of you had, particularly for things that were not mentioned already?
Talked about timeliness and ease of access.
Great. So timeliness and access.
finding the goal and making sure that we're maximizing gains of that goal.
Great. So clearly defining goals of what we're actually trying to accomplish in this care quality. Terrific.
But also sort of like a patient satisfaction element.
Great. So some component of the patient experience or patient satisfaction. How about to this side of the room?
I think we were big on outcomes, measurable outcomes that are also combined with good patient experience and patient-centric deliveries.
Great. Great. So a really important function of clinical outcomes, patient experience, and how those are actually achieved.
And access in a reasonable amount of time.
Access.
To that care. Yeah. And then we talk about evidence-based.
Great. So evidence-based care too, just something that's consistent. So part of why I think this initial conversation is so important, I hope it's one that you don't stop here, is I'll start with a rhetorical question, which is, in a group here of primarily healthcare providers, broadly defined, all of you use several different words to describe what quality means. What do you think this conversation would look like if we were a group of patients? How would it be different? What would this look like if we were a group of payers or an insurer? What would this look like, God forbid, if we were Congress, trying to help define what quality means? The second reason why this conversation is so important is how you define quality is critical when we start talking about how we measure it. So if we don't agree upon how we define it, obviously the ability to measure it becomes far more challenging. The third reason I think this conversation is so important and why I love starting a presentation with this is one on a more personal level. So if you think for a moment how you define what high quality care meant is likely going to have a significant impact on what and how you're influenced. Right? So if Maja and Weston decide that the primary way that you're going to deliver high quality care in LPP over the next year is the patient experience. It's the only thing you're going to focus on. For the 3 or 4 of you who said patient experience is the primary thing you would use to define high quality care, you're going to be on board, right? Because for you, that's a big part of your core definition. You're likely to be engaged in a different way. If, on the other hand, something else resonates with you, you're less likely to be engaged in that piece. So if access is number one, and you see most of the work and effort focused on access, you're going to gravitate towards access initiatives. So that's a really important piece, I'd say, from the organizational perspective. This is one of the challenges, which is how do we largely, broadly engage our entire workforce into doing improvement work? And if we don't have a collective definition of why we're doing what we're doing, or what are the key ways we're measuring what we're doing, and those are not linked together, we have all kinds of people coming with solutions for problems they don't believe exist. And we are really good at that at large organizations. So again, I want you to keep thinking about this very question quite a bit. We're going to spend some time now talking about what the definitions could look like, how we actually link those to measurement, but really on a personal level, this is what I want you to walk away with, which are what are the things that motivate you to improve the care you provide for patients, and what do you see around you? This gets back to the spirit of how many of you actually lead quality improvement efforts versus how many are the victim of someone else's quality improvement effort. Because we both have been on both sides of that, and so it's a really important paradigm. So this is one definition. There's the Institute of Medicine. This is a report that actually was really, really thoughtfully written back in 2000. It's not a report I would suggest you read from cover to cover unless you're looking for sleeping materials. It's really dense. But the key takeaway from this is really beginning to put this notion of what does high quality care mean? How should we think about it? How should we define it? Wow. And what are the tenets and principles behind it? And these were the 6 kind of aims that they defined, many of which you touched on. We talked about safety, so the notion of how do we actually reduce harm to the patients we care for. And remember, when people started talking about patient safety 10 and 12 years ago, most of what they were describing were what we call the errors of commission, doing the wrong thing. These were the wrong site procedures, wrong site surgeries. Now we have a far broader definition of what we think about when we talk about patient safety. We're talking about errors of omission. What are the things we fail to do that actually prevent things from happening as opposed to things we actively do that cause harm? And so as a result, you could argue, and it's debatable, whether are we more safe today than we were 10 years ago. And so there's a great line in the Institute of Medicine report that talks about the fact that medicine 40, 50 years ago was really simple, safe, and entirely ineffective. Now it is complex, unsafe, and incredibly effective. Right, so just if you think about what's happened in the evolution of where we deliver care for patients actually getting care in buildings, as opposed to 30 years from now, where we could argue patients may not actually be coming for encounters in what we currently call clinics and hospitals, the paradigm for what this means continue to evolve. So safety is a really big part of that. A number of you already touched on kind of the notion of effectiveness or evidence-based care, a lot on patient-centeredness, though that term continues to mean different things, timeliness, efficiency, and I'll focus on the last one of equity only because it's one that I think we have not even really begun to touch. You know, we live in a city that's unbelievably diverse. At UCSF, we have just launched a health equity kind of leadership council, and we want to start beginning to similarly define what those key areas that we could focus on and prioritize. And of course, in behavioral mental health, you guys live this every day more than almost any other specialty and field. And so how do we really begin to understand, are we creating disparities with many of the quote system improvements we're doing, and how do we know? Because if we don't know, we can't begin to assess how we actually improve. The other 2 words and languages I'll put here just because if you read the New York Times or your newspaper of choice, you know the term value gets thrown around a ton. So while the word value was not actually an explicit part of what the Institute of Medicine report defined, it was implicitly throughout the entire report, right? So the notion of value being the numerator of clinical quality and patient experience divided by the cost was of course the tenets behind the 6 aims, but that was exactly what we're trying to do. How do you provide high value care? My concern, of course, is many times right now when we're talking about value, what we're really talking about is lowering costs. And that's actually okay, let's just call it what it is. Like, we have things we have to do to make our system less expensive. Let's do that without affecting quality or patient experience. But value is a really big tenet of this. One of the anecdotes I've often shared is in my previous hats, we started running a medical student elective in quality and safety about 5 or 6 years ago. And early on, when the value equation started becoming popularized, we would turn to the group of senior medical students and be teaching about value, thinking we were giving them some profound framework in which we are now thinking about care. We would say, similar to what I just said to you, the purpose and goal of our healthcare system is to provide high value care, high quality, high experience at an affordable and low cost. What's the most common thing you heard back from medical students? What exactly have we been doing for the last 50 or 60 years? Like, why is that a new framework? Isn't that what we should have been doing from the start? Which, of course, is an obvious statement and just not one we have created the emphasis on. The last piece I'll mention here, too, for those that have followed kind of healthcare improvement is you've probably heard about the triple aim concept, which is the one I just referred to in the value equation. I can't emphasize enough how important this notion of the quadruple aim is. And this is actually was written about first by our own UCSF faculty. This notion that in order to provide all the things we just discussed in providing high value care, we have to be focused on our provider workforce, on all of us. Because in most non-healthcare industries, and as you'll see in a few moments, I have spent enough time in many non-health industries to actually understand how they tackle the similar types of problems. And what you hear in most of these other industries is when you ask them, who's your number one customer, quote unquote, they will invariably tell you that our number one customer are the people that work here. that if we actually provide the right, allow the people that work here to do the right thing at the right time consistently, we know the service and care, quote unquote, they will provide to their customers. That is something in healthcare up until the last couple of years was not a principle we really focused on. And one, while we have lots of work to do, one I'm glad we're beginning to emphasize in the same way we're emphasizing quality and safety and financial strength and other elements of our organization is how do we really focus on our people as a driver of actually achieving these 6 aims. And that is part of what the quadruple aim tries to get at. Let me make a quick comment about the notion of quality improvement, because as I've often joked, and Weston's heard me say this, is at some point quality improvement becomes so generic that it means everything or it means nothing. So the way I often describe quality improvement, and really this is about improvement work in general, rather than, as you've seen, a really broad definition of quality, is the idea that if we are actually assessing the care we provide today, in many cases we see a lot of variability in that care. And in cases where we know that the evidence or others would suggest, what we want, of course, is providing care that's far more consistent and reliable. So let me give you a couple examples just to help illustrate this and make a couple contrasting points for you to reflect upon. So one example I'm using here is door to balloon time. So for folks that have an acute myocardial infarction, the data began emerging rapidly over the last 10 or 15 years that the faster that person, individual, who is having a heart attack in the community, hit the emergency department, the time from the emergency department into the coronary angiogram lab and opening up that clotted vessel, we knew that their outcomes were better. And so large national improvement initiatives trying to dissect this process, and in fact in our own hospital, we went from that average time of you hitting the ED to having that vessel opened up to like from 2.5 hours down to one of the top 5 in the country at like 40-something minutes. And you can imagine that was an incredible amount of process improvement in saying, what are the different steps involved that allow us to become a better performing system? Right? So in multiple examples, one really concrete example that's gotten lots of popularization across the country, which is why this is spread in every other place. And we know that the biggest predictor of your outcome from an MI is actually how close you are to the care that you can receive, and that's not unique to heart attacks, strokes, and many other conditions that applies. Immunizations and cancer screening, another example where we have lots of evidence for what we think are the best guidelines to do that. And we also know when you start looking at how often patients get that care, it's about a coin flip. It's about 50% of the time. Now you could argue, is that a provider issue or is that the delivery system they're working an issue, particularly in the world of EHRs, that discussion is becoming far more interesting. And let me use the MRI and headaches as an interesting example of a place that I think we need to do more of, which is in the absence of evidence. So there are many things we do in clinical medicine that don't have terribly good evidence, or in particular don't have evidence for the types of patients we may care for, which of course is a constant tension. So this is a close former colleague of mine during my training. He was a surgeon, and he works at a large multi-specialty practice. And he got really interested in this notion of variations in care, similar to the graph on the left. And so what he did, he said, I'm going to start this experiment or pilot in an area I know nothing about clinically. So he went to his large multi-specialty practice, and they had a group of about 8 neurologists practicing, and largely a similar patient population. The overwhelming #1 diagnosis that clinic saw every year was a patient with a new headache. So he thought to himself, that's kind of interesting. What if I take the 8 providers and look at all of the patients that they saw for a first visit for a new headache and ask the question, how often do each of those 8 providers order a brain MRI for that first visit? So as he's starting to show the data, de-identified, and beginning to describe it as I am to you, one of the neurologists sitting in the front says, I don't know a neurologist within 100 miles of here who would not get a brain MRI for a patient with a new headache. What do you think the neurologist sitting right next to him said?
I do it all the time.
Oh, I don't do it. Sorry, he said everyone does it, and the neurologist next to him was like, I never get a brain MRI first time. So part of what he demonstrated is in this very practice, with 8 providers seeing the same patients, largely, huge 15, 20-fold variation in their practice. And so in some ways, this notion of variation reduction is actually a really, really helpful strategy in saying, should it matter for a patient, and should it be that dictated by who they see, rather than what they're being seen for? And so it's another interesting lens into when we don't have clear evidence, how do we use variation reduction as a way to start describing patterns, describing ways we think about it? So again, a great one to think about in your own practice or the own conditions you care for, which is when there is an evidence, how do we actually balance that variation piece? And lots of work we need to do in that way. The last piece on this discussion is also just to make what will sound like semantic, but an important distinction over the field of improvement work the last 15 or 20 years, which is at times this association as well as tension between performance and quality improvement. So I've given you one example where these 2 principles and theories are really well aligned, right? So the notion of performance improvement tradition, the science behind it came from how do you make the providers, the people in the system, actually work and perform to the best of their capabilities. Whereas quality improvement typically thinks about it from the patient's perspective. How do we improve the system to deliver that high-value care to the patient? Now, in many cases, you want those two to be aligned and one achieving the other. So the example of the door-to-balloon time for acute MIs, we could agree that in fact helping the performance of the people in the system in fact improves the quality of the care delivered to that patient. On the other hand, you can think of examples where those two may be at odds with each other. So think for a moment to yourself of a time or situation in which maybe where the performance is a big emphasis, it may or may not actually lead to the best quality of care. So hypothetically, let's say the metric or measure was a patient with mental behavioral health sitting in an emergency department should only be there for 4 hours and needs to be out within 4 hours. Now, you could theoretically achieve that through lots of different means and get the system to perform. I suspect all of you know better than me the unintended effects that could have as to whether that's really the most beneficial and meaningful care for patients, right? So in the ambulatory setting, this is the classic focus on productivity. That if you're constantly focused on what we call RVUs, right, how many patient encounters are you seeing, yes, that may help improve the quality for defining quality by access, because maybe you're getting more patients in, but in fact, maybe it's not actually helping because you're not giving the patients the care they need, the communication they need, the other pieces. So I think it's really important to think about this notion of how do we contrast performance and quality. So let me give you 2 non-healthcare examples to highlight this further. How many of you have had the pleasure of Subway? Those who have not, presumably at least familiar with the concept. I have become close friends with all the folks at Subway at Millbury Union because they know they landed a number of my talks. So Subway is a really interesting concept, right? The business model could not be more clear. What's the objective of Subway? Yeah, make as many sandwiches as possible. Right? So they do an interesting piece, which is they have lots of data, and they know, based on their registers, when the highest volume of sandwich requesters come through. So which is why if you go to our Subway at Millbury Union between 11:30 and 1:30, they are staffed because they know that is the busiest time that they have people heading the door. They typically have 5 or so team members standing behind the line at Subway. Now, what happens for those that have been to Subway? What's the first thing that happens when you approach and stand in line? What's the first greeting message you get from a person at Subway? And you don't have to be embarrassed. I can tell you this. I go to Subway now. Anyone know what's the first thing you hear from the front of Subway?
What type of bread?
Yeah. Welcome to Subway. What can I get you? Bread. What type of bread? Then what?
Meats, probably though.
Would you like it toasted or not? Right. Then it's the condiments, right? And then would you like a meal? And then it's checkout register. It's unbelievably efficient, incredibly consistent, largely, and they're trained that way around it because again, their primary objective is to get as many sandwiches through in that high peak time as possible. Now, if you go outside of those 2 hours, you know that they tend not to have the staffing the same way. So as they joke, if they get the bolus of medical students let out after a 2 o'clock lecture and 30 people show up, they look like what we look like in the hospital when we have the high capacity load, or we're not staffed to that, because we staff based on what we think is predictable, and we can't predict the unpredictable. Now, the other piece of this model, this is the focus on performance improvement, is what happens between 11:30 and 1:30 when Subway's working at that pace. Occasionally what will happen is they'll throw olives on my sandwich. I'm not a big fan of olives. So they'll pick the olives up. Now the sentinel event for me is if they actually lather my sandwich in mayonnaise, in which case, me personally, not a big fan, and therefore the sandwich gets remade or gets redoctored. Now what would happen if I, or any of you, went to Subway 5 days a week, and 3 to 4 out of those 5 days, they were making your sandwich with olives and mayonnaise? What would you do the following week? You go somewhere else, right? So think about the business model for Subway for a moment. Subway is saying we are focused on performance improvement, and what we realize is occasionally, at some acceptable error rate, we're going to occasionally throw olives or mayonnaise on someone's sandwich, and the hope is we don't do that enough to actually detract people away, and if we do some service recovery, it happens, they'll apologize, I'm really sorry, we'll make your sandwich. Right? So they have some estimated calculation that's purely based on trying to get as many people through in a performance improving fashion. So let's contrast Subway with the following example. So how many folks have flown in or out of San Francisco International Airport? And how many people have had the pleasure of a delay at SFO? Yes, all the same hands go up. So if you're unfamiliar with SFO, this is an image, aerial image of the runways. Now I'm not a meteorologist, but I'm pretty confident that fog did not appear in the Bay Area when these were designed. Now what's fascinating about SFO is that these 4 sets of runways, the 2 that run perpendicular to each other, they make a very, very different decision in the spirit of performance versus quality improvement. So what they do is when they have visibility that hits around 1,500 feet, they ask no questions, they shut down the runway. So think about that for a moment. Who's happy about the fact that they've shut down a runway? Right? They have the same metrics for time, takeoff time, delivery times, baggage claim. There's people like us who are trying to make connections, get to places, vacations, business trips. Nobody's happy about the fact that there's delays. What I would advise is we should be, because the decision they're making is actually for our safety. They are saying that at some level, the risk of significant harm, significant error that would occur with that level of visibility is not worth the performance effects that it will have. So next time you're at SFO and there's a delay, go up and hug the flight attendant. Tell them thank you for keeping me safe. Because that's actually what they're trying to do. I've yet to see that happen. I've yet to see anyone walk up behind the counter and say, thank you for making me delayed because I know you're really focused on my safety. But in essence, that's actually what they're trying to do. So I use these two contrasting examples, and then I ask you the following rhetorical question, which is if you think about your own clinical practice setting, for those of you that work in a clinical practice setting, does your clinical practice setting function like Subway or SFO? And I ask rhetorically because my suspicion is there are days where it feels like Subway, and there's days where it feels like SFO. And it is a real tension. There's no happy, easy answer for it. We know that the capacity pieces are really challenging, the access pieces are challenging, inpatient, outpatient. This is a real issue, so just to acknowledge that there's a tension here between the concepts of performance improvement and quality improvement. And what we're trying to do is say, how do we actually connect them in meaningful ways? Because the processes behind these are actually similar. Whether you're focused on a performance metric or a quality metric, or if they're one and the same, ultimately what you're trying to do is improve processes, which is the definition that a number of you shared at the beginning. How do you break that piece down and say, how do we assure that in the system we work in, it works as efficiently effective as possible to meet the design goals or outcomes we're trying to achieve? Okay, so that is why it's so important to make sure that we have a similar operating model about how we define quality, because you can't begin to measure it or come up with measures unless there's agreement on how you're defining it. And so what we're going to do is we're going to spend a few minutes talking about quality measurement. And this is a good example where I'm giving you a framework that is not unique to healthcare quality, though it comes from there, and have you reflect a little bit on, as you're already hopefully doing, thinking about, I wonder how the care I deliver, or the care we deliver at LPPI should be measured, could be measured. Is it meaningful? What are the trade-offs of the different measures and metrics? So we start with a different question, which is, back in 2000, in the same year that Institute of Medicine report came out, the Consumer Reports did one of their usually very sophisticated polls, surveyed about 1,500 providers across the country, and asked this question, a version of what I asked you at the beginning, which is, what does high quality care look like? What do you think the number one answer was? It was overwhelmingly the number one answer in response to this question. And the hint here, it's not nearly as sophisticated as all the answers you gave at the beginning of this discussion. What would you guess? What would you guess was the prevailing answer to what does high quality care look like when answered by about 1,500 providers?
Getting people healthy fast.
Getting people healthy fast. That's far more aspirational than they were actually thinking at the time. Number one answer, I know it when I see it. Now sadly, this in some ways is not a completely lost paradigm. There are still many who believe this is actually, and this is part of a limitation of how we actually measure. Anyone know where this phrase actually became popularized? Any history buffs?
Yeah, it was in the Supreme Court.
Yes, so this was the famous Justice Potter Stewart when presiding over a case where the debate was, how do we know if this meets the criteria for pornography? His statement was, I know it when I see it. Not that I'm equating pornography to quality. But the principles here are, right when you're trying to describe something that felt so abstract, like, of course I know what high quality care means. I know it because I see what it feels like, I know what the experience is like. I don't mean to minimize that, like, that's actually not an irrelevant part of the definition, but it's not one that lends itself well to saying, how do we know if we're actually achieving it? What does that look like? Which gets back to your initial reflection on what does high quality care mean to all of you. So if I were to ask you, and here similarly, if we were doing this in a larger workshop, I would have you actually spend time thinking this through, which is, if you were coming up with, these are the 5 or 6 things that I think would be really important for us to be thinking about in the taking care of patients with mental behavioral health, what might that look like? Part of what I want you to do is in your head to be thinking about a few of those already. You've mentioned a number of them at the beginning, but that discussion was really focused fairly 30,000 foot level of how do you define high quality care. Here I'm asking you to think to yourself for a moment on what might that look like specifically for the patient populations you care for. What are the ways you can begin doing that? And so the framework I'm going to give you is the following, with a couple really key important points. So the first is the first bullet point here, is there's never feedback. And we started actually doing the observations, started feeding back the data at the unit level, at the service level, and even by discipline. Right, so now you start to be able to show which areas, which providers, which groups were actually starting to do this in a more kind of adherent fashion. Then what happened? So what do you think happened between when you combine the education, system change, audit, and feedback? Of course, it's a leading question, but what do you think actually occurred across the hospital with those three interventions? Any guesses? So this is where the story gets interesting. So in some areas, it went to 95% sustained compliance. In other areas, it sat at 60. And so the question is, what was different? Same three buckets in one area, different in the other areas. And this gets to the kind of often opaque culture. And what I mean here by culture is really culture is defined in the local areas. What are the norms, behaviors, attitudes that allow all of us to practice certain behaviors because that's what we expect and that's what we see around it. We've done a really, really kind of comical, didn't intend to be comical, ended up comical, mini study where we actually followed, on medicine we have often gaggles of people on our rounding teams. And we did a little study asking the question, or the hypothesis was, what's the biggest predictor of whether the entire team goes in washing their hands or nobody goes in washing their hands? What do you think was the single greatest predictor? Yes, so yes and yes. So the attending was the most common guess as to what would be the predictor. It turned out not to be the case. The number one predictor was what the first person did. So if that first person was a medical student and that medical student gelled, everyone behind them gelled. If that medical student didn't gel, about 50% of people behind. It was a really powerful kind of observation set of norm. This is what we know about culture, which is it's really set locally in the microsystem and what that looks like. So again, I use the hand hygiene example. You can translate this in any way you think for the work that you hopefully get involved with in some improvement, which is think about those four pillars. How do we translate all four of those elements into really feeling like there's ownership? On the units that went to 95+% and sustained there, one of the biggest contributing factors was an amazing partnership between the physician and medical director and, in this case, the nurse manager. And the two of them paired it together, they championed it together, they cheerleaded together, they did real-time coaching in a non-threatening, culturally reinforcing way when they noticed and observed someone was not actually doing it. That was a big part of what helped drive it. And I'll finish by saying that, in fact, this is actually something we learn in kindergarten. Kindergarten is a great place to learn behaviors that we then spend the rest of our life forgetting, for those of you that have kindergartners and interacted with kindergartners or previously had a kindergartner. So this is actually a close colleague of mine, his son. We happen to share the same first name. After his kindergarten year, we were over at their house, and I migrated over into his bedroom to ask him how things were going and how kindergarten went. And of course, this is after we do the requisite support group on our name. How's the name treating you? Are people pronouncing it okay? He had just come back from Disney and was really bummed out that he couldn't find a pre-printed Niraj on anything. And so I was like, yes, I've been there. Don't worry, you'll come to appreciate the uniqueness of your name as you grow older. And so I noticed over his shoulder this like fascinating piece, which was he had this dashboard. So I thought to myself, I wonder if the four pillars actually apply to a kindergartner. So on his dashboard, which you can't see, these are the four metrics. So I asked him and I said, hey, Niraj, do you know why it's important to brush your teeth in the morning and evening? Clearly two metrics that have been prioritized. And he said, well, if I don't brush my teeth, I get cavities. I was like, check. He's gotten the education. He's clearly getting the audit and feedback. Right? The system change was a more challenging conversation. It was a little bit like, what happens if you don't brush your teeth? And it was like, well, I don't get dessert the next day, was a bit of the forcing function. And the culture, right? They're making some decision on reinforcement and what they value. Whether these are the right 4 metrics or not is irrelevant. The point is you're trying to help highlight how we actually go there. Now, as a safety person, I, of course, went over and I was like, there's a defect. What happened on Thursday? What can we learn from what happened? So what happened this morning? And of course, he then went on to tell me that that was the morning that mom went to work early, dad not quite as organized and just told me to get in the car and don't brush my teeth. Needless to say, I don't get any unsupervised visits in their house anymore because they worry they end up in my talks overall. But I think it's a really illustrative example of this notion of what those 4 pillars really look like. So let me finish with a couple take-home points that I hope have been reinforced. The first, I hope clear, there's no single best way to measure quality. You need multiple lenses in the same way all of you reflected at the beginning and what those terms mean to you. The second, and we are really good at this, we are unbelievably focused on what we measure. And if we measure the wrong things, we will focus in the wrong places. And that is the ultimate thing that probably keeps me awake at night, is how do we continue to focus on the right things, not on the things that everyone else may deem right, but may not actually be the most meaningful. And there is a tension there. I don't pretend to balance it perfectly, but I think it's a real tension all of you should also think through. The second, and I hope this is clear, is the externally driven world is going to continue to change. It's going to feel irrational. This is not even talking about Congress at the moment. Like, it's going to feel irrational, it's going to feel unpredictable. And ultimately, that's why the message for me is always, how do we just continue feeling we're getting better? How are we better today than we were yesterday? How are we better this week than we were last week? How are we better this year than we were last year? Because ultimately, that's the thing we can control. We can't control who's going to put what in front of us and deem something important. What we can focus on is ourselves. And that leads to this last point, which is that the data is unbelievably important. But now, having gotten the breadth of our large organization, I can tell you story after story that the biggest reasons that places have made a difference, it's almost never about the data. The data helps. It's always about the people and the culture they're trying to cultivate. So my charge to all of you is to please try to be part of that, because this is not a pure directive of quote-unquote leadership. This is really about what happens at the bedside, what happens in the support areas that help actually allow all of us to care for patients in the way that I thank all of you for your attention. I realize I'm at the 1 o'clock or 2 o'clock. I'm happy to stand up here if folks have questions, but also please feel free if you're running late to your next subway appointment. I do not want to stand in your way. So thank you guys very much.